Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for the second season of conversations aiming to bridge gaps surrounding dysphagia intervention. Swallow the Gap podcast is a production of Gap Education, and we are predicated on a mission to improve dysphagia care. Nothing we say is legal advice, nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, therefore our guests will not always reflect what we believe. In fact, we may change our minds as we learn more because this is how progress is made. Through critical reasoning with open minds, we serve as catalysts for advancement in medically focused speech-language pathology. This episode of Swallow the Gap is sponsored by Bracco Diagnostics. Bracco is the maker of Veribar barium sulfate, the only contrast validated for standardized, well-tested protocols during modified barium swallow studies. For more information, visit veribarmbs.com.
Hey everybody, welcome to Swallow the Gap. This is not Dr. Tim Stockdale. This is Dr. Jeanette Benigas. I have pushed Tim out of the host seat into the hot seat, if you will. Today, I am going to interview Tim about the normal/functional swallow.
You think it's fair to say you're going to... Yeah, that sounds all right. But you think it's fair to say you're going to interview me because I know that you have some pretty good input for this too. So it's going to be synergistic.
I'm going to try not to hijack this thing because that's what I do. So I hijacked the intro. I didn't tell you what I was going to talk about, but we know what we're going to talk about together. So you're trusting me to have some things to say right now. And so I just want to intro this with something that I often discuss with folks. I'd say as far back as maybe 2 years ago, I've been talking about the changes in what we consider normal or functional in swallowing and the differences in how we treat those and how that has evolved over the years. Because a lot has changed over the last 20, 30, 40 years in swallowing treatment. And I did a little research. I think a lot of us think that Jerry Logeman's 1998 text was like the seminal first book in dysphagia treatment and management, but it's not. Before we got on, I did some research, and there was actually a text by Michael Grower, 1984. Dysphagia Diagnosis and Management was the first hot book on the market. Then we had Logeman. So this book, Logeman, it was written, it was well done, we all used it. No, I'm saying the right thing. Logeman, textbook, Logeman, the red one.
Okay, I'll cut that out.
Okay, yeah. So we all used it, we all loved it, but we had very little research and evidence to support what we were doing at the time that she wrote that book. She did what she could with what we knew at the time. And obviously, since 1998, we have come a really long way, including the things that we know are normal and what's not normal, and the treatments that we use for these things, or do we treat or do we not? So that's really where the push in our field has been going. And I just wanted to compare that to, very briefly, the advancements in HIV/AIDS treatment, because that started around the same time. HIV/AIDS treatment started in the mid to late 80s and has advanced quite a ways. So back in the mid to late 80s, there really wasn't any treatment at all. If you got that diagnosis, you died. Then it became 16 to 16 pill regimen that you would take in the late 80s, early 90s. And now we have a long-lasting single pill capsule with a great prognosis for people with this diagnosis. And really, we're moving towards immunization and perhaps elimination of this disease completely. And so if someone were to get that diagnosis of HIV/AIDS today, do you want your practitioner to base the information on today's information, today's treatment, today's science, or do you want them basing your treatment and management on 1998 knowledge, 1998 science, 1998 treatment? Nobody's going to pick 1998. Science has been allowed to advance, right? And we see this with cancer as well. Lots of scientific advancements. However, what we see in our field is, this is the way I've always done it. This is what I learned. This is what I know works. I'm an expert, when really, making, Yanessa Humbert said, doing the same thing the wrong way for 19 years doesn't make you an expert. It just makes you doing the wrong thing for 19 years, something to that effect. We see a lot of resistance on change. And so that is why people like you, people like me, we've got other really, really great educators out there harping on this stuff over and over and over again, because we need to keep hearing it. We need to be allowed to advance and change, and we have to keep up, because this is happening fast. We now know so much more about the swallow than we did in 1998 when that book came out, or even before, when the one came out in 1984. So Tim, you're a great case study. You've got some special things about you. I would love that you post either your fees or your MBS or the side-by-side. Post that, because people are probably going to see your social media without listening to this podcast first. Post that and do a little box that says, how would you treat this patient? And I would love to see the answers. How are we going to treat Tim Stockdale and his crazy swallow? Because that's what he has, is a crazy swallow. Tim, do you have any history of pneumonia?
I mean, maybe when I was like 3 or 4.
Okay. So
probably,
maybe not of the oral bacteria infiltrate type. That's not.
Could be, but probably not.
Okay. Generally healthy.
Yeah, generally healthy.
Are you drinking thickened liquids? Are you doing the chin tuck? What are you doing for that?
Got my cup of water right here.
That is like a beer for anybody who we're not filming this, so it's
root beer.
It's a beer stein size mug.
It's an A&W all-American food root beer mug.
It looks large. So you're swallowing your liquid right now, probably aspirating, probably doing a multi-swallow thing. You're not standing on your head. You haven't joined the circus. You're not doing all the tricks and the things that we tell people to do, and you're not thickening liquid. So what is that? Talk to me tell us about your swallow. How is it different than mine?
Okay.
And is it functional?
To be fair, I haven't seen your swallow, but I'm going to presume that it's not
perfect.
Like mine. It's perfect.
It's
okay.
Perfect. We just saw it 17 times at our CEU event a couple weekends ago.
Okay. Fair enough.
I saw it. It's fine.
Well, so recently we, as Jeanette and I were teaching this fees course, to prepare for it, I went to an ENT's office, Dr. Ryan Stevenson in Provo, Utah with Peak ENT, and they did for free a simultaneous video fluoroscopic swallow study and fees. And on this, the speech pathologist keeps going, swallow, swallow, and I'm looking and I'm like, oh, that's interesting. I'm seeing a lot of residue in my throat as the ENT scopes me. I'm looking, my epiglottis is not fully inverting when I'm looking at the fluoroscopy, which wasn't so much of a problem from an airway protection standpoint. I was protecting my airway quite well, but it's very inefficient. Very inefficient. You look at some of the data that I believe Katrina Steele has published to look at, like the typical number of swallows on certain consistencies. I think is maybe 1 typically for thin liquid, sometimes 2 on the fringe 3. And mine was pretty typically like 4 or so. And there would still be some residue in the vallecula and the piriforms. It was very interesting to me. And so it cleared my throat a lot. I thought I just had a lot of postnasal drip, a lot of sinus issues. But come to look at this, I'm not one to overdiagnose dysphagia. I'm sure, done it recently, but I'm very cautious about this. But I would probably diagnose myself with dysphagia, with a swallowing inefficiency. And so I uploaded the video fluoroscopy of this to YouTube. I'll probably put it out on my Instagram, maybe even a comparison so you can see the two to get an idea of what you think with it. But yeah, it was very surprising to me. I was like, oh, okay, well. But so back to your question, the idea of typical versus functional, I don't know recently of any pneumonias, of malnutrition, dehydration, maybe quality of life issues. Yes, I'll go into that related to dysphagia. But if I, during my clinical fellowship or even a year after that, would have looked at this swallow, I probably would have prescribed some different strategies and stuff. But the thing that I think we've missed is we look at what is typical. And think about this from any sort of anatomical or physiological perspective. Look at what's typical with a person walking down the street. What's their average stride length? How tall are they? You know, the average man, what, 5'9" or 5'10" or something like that. So what if you're 6'4" or 6'5"? You're not typical. What if you're 5'1" or 5'2"? You're not typical. Does it matter? And why does it matter? If you're 6'4" or 6'5", you're going to have an advantage. You might be better at basketball because you're closer to the rim, etc. Different things. There is diversity in how we look, and it doesn't always, whether it's height, whether it's weight, doesn't always necessarily impact us in a negative way. It can, and so that's when we need to watch out. So for swallowing, for me, if we're looking at what's typical and atypical, which there are a lot of more norms coming out for that, there's actually, if you haven't seen it, in 2023, look at JSLHR reference values for video fluoroscopic measures of swallowing, an update. It's with Katrina Steele et al. And there are some norms published on how often they saw these individuals with a PAS of 2, a PAS of 5, and it's probably a little more likely than you would think. But anyway, whether or not I'm aspirating occasionally or I have an inefficient swallow, we have to have these anchoring points. We can't just look at it for the sake of, oh, that's different, so I'm going to treat you differently. You're outside of the norm, so I'm going to penalize you, or I'm going to recommend thickened liquids or a chin tuck or something else that potentially is going to have some other negative health repercussions. It's important to look at, is this person malnourished? Are they likely to be undernourished? Are they going to be dehydrated, or are they now? Is their quality of life impacted? And then, of course, the one that we're really good at looking at, or we look at least a lot, is pneumonia or asphyxiation. Is there going to be some sort of pulmonary sequelae, some sort of insult to respiration or ventilation, right? So in considering that and looking at me as an exemplar, as one of many, so no pneumonia, no malnutrition or undernutrition that I'm aware of, no dehydration that I'm aware of. But I'm looking at this, my quality of life, yeah, it's been impacted some. I don't like clearing my throat all the time, and now I know that that's largely because of dysphagia. So that would be an impact to me on something that's annoying. Someone else, they might not care about that. It might not bother them, but they might become malnourished. And so my soapbox with this is we've got to step back. We've got to apply evidence, not just to what we see, like did someone aspirate? Are they swallowing 4 times and there's still residue in the vallecula? And just saying, oh, that's not what I'm used to seeing, so I'm uncomfortable with it. We have to look at it and say, is this right now impacting a health outcome or their quality of life?
Yeah.
Or is this likely to, in the future, impact their health or quality of life? Because you think of somebody with head and neck cancer and the effects of late radiation, it might not be impacting you now, but it might later. So preparing them, say, hey, look for these things. Do these, under these circumstances, you might want to do X, Y, Z, or whatever, preventative measures. But this is also something that's so much broader than us, and it emphasizes the need for us to have more interdisciplinary science, for us to collaborate with physicians, with dietitians. There's been a lot of good information about the benefit of collaborating with dietitians. Ed Bice et al., I forget who else was on that with him, but I know Ed Bice has looked into that some. And so anyway, I could talk about this for a long time, Jeanette. I'm going to turn it back over to you so that I quit rambling.
It really is just what I think you have called an urgent shift, right? We're shifting from prescribing monkey tricks, which is, I always tell my students, we're teaching people to be in a circus. And really, we know that. I think I did part of my doc program with Dr. Jim Coyle, and he always says people are going to do like half of what you tell them to do. So if you're telling them you have to do this chin tuck or turn and swallow or cough and swallow again and breathe and swallow, if you're teaching them all of these tricks and that's what they need to do to, quote, be safe, they're only going to do it half the time, if that, if ever. So what we need to be looking at is shifting from teaching the tricks and the things and thickening it, which we know from as far back as Logeman et al. 2008, Robbins et al. 2008, then Native Zeltzer et al. I think 2018, 2020, somewhere in there, there's some studies. Those treatments that we're prescribing are doing more harm than good. I think before we hypothesized it, maybe back in the early aughts, but now we know those treatments, not sometimes they help, but generally when we're overdiagnosing, overtreating, we are contributing to iatrogenic illness and making people more sick. And so now we're seeing this shift to stopping that practice to focusing on patient health, patient well-being, identifying that maybe their swallow is functional for them, even though it's not what we assume is normal. We're looking at nutrition, hydration, and not just nutrition and hydration through a tube, but oral nutrition and hydration. And maybe there does need to be a tube for some supplemental. Again, every case is different. We're not saying don't ever use those things, although I don't like them. But remember, I come out of the dementia world, so that's a whole nother ball of wax. Someone in acute care, maybe there's a time and a place for some of those things. But we're looking at nutrition, hydration, and truly quality of life, patient preference, supporting patient preference across the scope, not just in a nursing home, but also in acute care or inpatient rehab or home health. How can we support these things in every setting? What are the patient's goals? The patient should be the number one on the care team. And they might not have the medical knowledge that we have or the doctor has or the dietitian has, but they're an expert on themselves and they know what they want. And so that's really where I think the shift is. Do you agree, Tim?
Yes, I believe so. And I know you mentioned a couple of articles. And so those articles, I think, contribute a little bit of evidence, and not a little bit of evidence, but they contribute parts of evidence. But I don't want to say that we can take one of those articles and take like all these points away from it. I think it's an amalgamation of several different things. So yeah. A few that I want to look at here just briefly. You talked about us sometimes providing intervention that results in negative outcomes, iatrogenic, hospital-acquired infection, that type of thing too. And so I want to take a look at that a little bit more deeply and put some data behind it. In Patel et al., 2018, well, this is just for patients with dysphagia. We know that dysphagia can contribute to increased length of stay, and according to this, mean hospital length of stay was 8.8 days for patients with dysphagia compared to 5 days for patients without. Inpatient costs were about $6,000 higher. They were 33% more likely to be transferred to a post-acute care facility, and they were 1.7 times more likely to die in the hospital. So dysphagia is a big deal. Like, nobody is debating that it has negative repercussions. It just might not always be the way that we look at it. And so some other articles, Yarrow et al., it looks at undernutrition. And so undernutrition is associated with several different complications, are a response to things that trigger our immune system. So they're saying that malnutrition is associated with emphysema, pneumonia, anemia, GI tract atrophy, intestinal bacteria growth, and increased infection rates, right? And so where does this factor into what we're doing? The tie is, if we're talking about, in particular, modified diets, particularly like pureeing foods or mechanical soft diets, if you're looking at that's all that I can eat. You're in the hospital, all that I can eat is a pureed diet. Maybe they just took it out of a spoon and slopped it on, and they didn't necessarily shape it to make it look like the food, but it's not something you want to eat as much. And so the tendency could be there for individuals to lower their nutritional intake. And not only that, if you're pureeing something, you're adding a lot of water content to it, so it's much less nutrient dense. So you have extra water content, causing it to be less nutrient dense, and you might not be eating as much. And so the idea with that, if we're asking why this matters, is because of the potential contribution, not only to quality of life issues, because people don't want to eat it, but issues with undernutrition. right? And so if we're intervening for somebody and prescribing a modified diet when they don't need it from a functional perspective, but then we're subsequently causing harm to them, then we're doing more harm than good. And so that's why it's important for us to calibrate ourselves with, okay, this person has dysphagia, but what's the risk that they're going to choke, or they're going to asphyxiate, or they're going to get pneumonia, or become malnourished, or whatever? So we have to look at those things. We have to go beyond just what we see. A couple other thoughts here. So you mentioned Robin et al. And Logeman et al. So from my understanding, this is the same cohort that they looked at. So in Logeman et al., in both of the studies, they looked at the chin tuck with basically trying to mitigate aspiration, the chin tuck versus nectar-thick liquids versus honey-thick liquids. And so there are two important parallels to be drawn from these studies to put together, because Logeman with this cohort showed that participants with the chin tuck aspirated more. Patients with nectar-thick liquid aspirated more than honey-thick liquid, right? And so if we're trying to just eliminate aspiration, it's clear. Use thickened liquids. It eliminated aspiration more commonly than the chin tuck did. But if you step back a little further, Logeman also says patients preferred the chin tuck. Okay, so we have that component in their patient preference. So we're looking at quality of life. But the big kicker is when you follow up with Robbins et al. In 2008 and seeing the negative outcomes, that those who are using the chin down posture had a lower prevalence of dehydration. So 2% versus 6%. They had half as many urinary tract infections about, and they had fever half as much. And from my understanding of it, it's not like pneumonia rates went way up. They were relatively comparable, but you see all these other negative outcomes that are coming with the intervention we prescribed. So to me, this is an exemplar of, look, you eliminate aspiration more, you get rid of more aspiration, but you're actually causing harm in the long run, because these patients didn't get sick more who are doing the chin tuck and were aspirating more, but they did actually get dehydrated more, have more urinary tract infections, get fever more, and that type of thing. I'm just bringing you a brief interruption that helps to keep this podcast going. There are hours and hours that go into producing each episode, and I'm very thankful that Bracco Diagnostics is sponsoring this episode of Swallow the Gap. Bracco is a maker of Veribar barium sulfate products, which are FDA approved and the only premixed, pre-measured, and precise barium products for modified barium swallow studies. For more information, please visit veribarbmbs.com. That's VARIBARMBS.com.
They also had longer hospital stays. The thicker the liquid, the longer the stay, which correlates with, was it Patel that you opened with, saying there were longer hospital stays?
Yeah.
So this one came first, 2008 came first. And just to clarify, the Logeman et al. Was done first. They were looking at immediate elimination of aspiration with those three. And then they used that same cohort, and there was some attrition. There was 700 something participants in the first, and then 500 something in the second. So they followed them long term, and they followed them until development of pneumonia, death, or 3 months, which is what they defined as long term. So they were looking at that long term use, like, okay, like you said, we know this eliminates immediately, we're eliminating aspiration, but what does this do in the long term? Because before this, there was nothing. We just suspected that, you know, maybe it was helping or maybe it wasn't, but there really wasn't any evidence to say one way or the other. So it was really the first study that looked at this, that and then called out, we can't say definitively that this is harming people, but it looks like it, and we need to be able to know for sure. So that was something they called out, was we need to look at this further.
I just aspirated. I'm not kidding.
Tim just had an event. I saw it. I think I aspirated. NPO immediately. Right. NPO. Oh my God.
I was getting ready to say something. I think that's attention too, thrown into that.
NPO.
Oh, dang, man.
Put in the tube.
Okay. All right. So I can't go a whole episode without having at least one flub, you know, right? And so earlier, not just did I aspirate on video, probably, I don't have x-ray vision, but I also earlier, I incidence, prevalence, I may have said incidence when I meant prevalence, or prevalence when I meant incidence, or maybe I didn't know which to say. I think that is more likely the case. So the rates of dehydration, let's just say that, because those two concepts, man, They tick me off. I feel like I can get a lot of other things right, but I'm going to, for the rest of my life, have incidence and prevalence. Just like on the moment.
I'm glad that you addressed that because we both have advanced degrees where we've been trained in this stuff, and even we get confused. And I think it's really important to continue to present yourself in a way that shows
Authentic.
people, hey, we struggle with this stuff sometimes too, and we're all in this together. And, Tim, that's his area of weakness. He has to learn the difference.
Well,
He's going to keep growing.
To say even us makes it sound like we're cooler than other people, which
No,
we're
I'm
not.
just saying.
I'm not, at least.
No, I'm just saying, like,
we're looking into this a lot. We're passionate about it, right? And we have experience, but at the same time, yeah, absolutely. You've got to be sincere. You've got to be genuine, which I think is a really good point to add on to what you were saying about in the past. You were talking about how with Logeman et al. In 2008, that thickened liquids reduce the occurrence of aspiration, right? And so
immediately, yes.
Yeah,
at first glance, immediate elimination. Yeah. The best thing to use was the honey, then the nectar, then the chin down posture. On immediate look on fluoro, that's what they saw.
And so, based upon a little bit of information, you would think that, look, we did it. We kept stuff from going into the airway, and we know that stuff's not meant to go into the airway. You're not meant to take in fluids into your airway. I mean, it happens occasionally, but that's not the way it should be. And so just at a very surface glance, you're thinking, oh, well, of course it's going to be better. We're preventing stuff from going in the airway, but with longer outcomes when we're asking why and not just being stuck in system one processing, but we're trying to critically reason, critically think through this. And we think, okay, well, it reduced the number of aspirations per swallow, whatever. Well, not talking about aspirating multiple times per swallow, but like, if you swallow 10 times, how many times you aspirate, whatever. But you got to look into it further. Why does that matter? And so I think that this really shows the importance of asking why and looking beyond that. There was totally another point that I was going with, and I lost it.
It'll come to you, and your listeners are so gracious. They're going to let you skip
they
around.
Have to be.
Or if you get totally crazy, you can cut it when you remember and stick it in where it belongs and cut out what I'm saying right now. But I always vote for just as little editing as possible.
No. Yep. No, I want to leave it. I think I'm planning to leave it. Let me throw something else out there. So as far as putting more data behind knowing whether or not our interventions are helping or harming, Whalen et al. 2001, and I think this was cited, to be fair, is it Yarrow et al.? It's not Yarrow et al. I'll have to throw a link in the description because I don't have it off the top of my head. But this article was Vivanti et al. Yeah, I think it's Vivanti et al. So in Whalen et al. 2001, that Vivanti et al. Cites, they're looking at this cohort of patients, and they found, I forget how many it was, I think it was like 20 or 25 or so, but look at the study, don't take my word for it. Those who were on thickened fluids, they only met about 30% of their recommended hydration needs through thickened fluids per day. They're recommending 1,500 milliliters of fluid a day, and about 30% of that was met through hydration, through thickened liquids. But they're meeting some of it through the foods that they ate because of the water content within the food. But this is the kicker. No one, not a single one of them, was meeting their estimated hydration needs without enteral or para-enteral hydration, who were on thickened fluids. Not a single one of them. And so when we're going out and recommending thickened fluids, which we do too much, that's not necessarily to say you don't ever do it. There could be a patient that will benefit from it, we'll see, but also being aware of how that's going to potentially negatively impact their health and quality of life. And so considering those things. Anyway, I'm saying the same thing over and over and over.
But we need to keep hearing it. We need to keep hearing it. And we need to keep educating our colleagues, and not just our colleagues in our own field, but like you said, physicians, dietitians, nurses. Because if this is a hard shift for us, think about how hard it is for these other healthcare providers to shift. They're not in this space, they're not in this world, and they don't get it. And the question is, well, if this worked 5 years ago, if this worked 10 years ago, why are we changing it now? And that's where I circle it back to the cancer treatment or the HIV/AIDS treatment. And I have to explain to people, swallowing, the process of diagnosing and treating swallowing and swallowing disorders is not that old. It's about a 40-year-old practice. We put the cart before the horse. We did what we could with what we knew at the time, but now we know more.
Well,
Funding and research has gone into developing a stronger knowledge base. And so we have to change our practices. And when you frame it like that, other people in healthcare can understand. This is why I'm doing it differently. This is why your last 3 speech pathologists didn't do it like this, but things have changed. And we want to provide the people we're caring for the very best that we can. And sometimes that means changing the recommendations, not using the types of recommendations that we used to make, or making some recommendations, but then supporting patient choice because it's their right. Patient Self-Determination Act of 1990 defines that people can choose their own medical care, and that includes a prescribed diet or a chin down posture or whatever it is that we might contribute to their long-term management or short-term management of their issue. They have the right to say no. And then we need to just pivot and support those choices because number one, we're here to support our patients, but number 2, it's the law.
Yeah. Something I think that is really important about what you said, if people are asking, why are you doing this differently than people who did it before you, you consider advancements in science, advancements in data, in our ability to critically analyze what we see. It seems, it has such face validity that we reduce the amount of aspiration, we reduce the frequency of aspiration, that's a better thing, right? It seems intuitive, it's got face validity. So it's taken years and years of studies to show that that's not necessarily always the case. So if somebody, like with using the chin tuck instead of using thickened liquids, and I want to be very careful not to take this particular cohort from Logeman et al. And Robbins et al. And to pretend like it generalizes to everybody, to all of our patients. It's limited in that, but there is still something to consider. Yeah.
I just want to say, I don't think you introduced who the cohort was when we started talking about it. So just in case our listeners don't know, everyone in these studies had dementia, Parkinson's, or both.
Yeah. So
these are long-term chronic cases of dysphagia. They weren't going to necessarily get better, potentially only worse.
Yeah.
And that's why they looked at immediate and then defined long-term as 3 months for the second study.
Yeah. I mean, the main thing is I want to acknowledge the limitations of these studies. Every study you look at has internal validity and external validity. The internal validity is, does it really do or prove what it says it was going to prove? Does it really measure what it says it was going to measure? But the idea of external validity is, how does it translate to your patient population? And so there are certainly limitations in that. So I don't want to make too many generalizations, but what it's showing us is that what is intuitive and what has face validity is not always the most true or the most right thing, that there are a lot of other factors. And so just considering somebody who aspirates, okay, so for them to get pneumonia, and caveat, I'm not a physician, ask a physician if you really want a thorough picture of this, but for someone to get pneumonia, you need a pathogen, right? And so individuals with a lot of oral bacteria, and they aspirate and they carry the pathogens down into their lungs, they're more likely to get pneumonia than somebody with a clean mouth, of course. But consider the idea of cough and so many other things. So what I'm trying to do here is I'm trying to think what we're afraid of, aspiration, but then asking, why does it matter? And so it matters from different perspectives, but if we're just looking at pneumonia, the potential for pneumonia, then we have to step back and say, okay, what else contributes to the potential for getting pneumonia? Because somebody could aspirate several milliliters of liquid and they have a very intact sensation with the recurrent laryngeal nerve, and they have a very forceful cough with a great compression phase, and it's just going to shoot like a cannon and get that stuff out of there. They're probably going to be a lot more safe, in my estimation, of somebody who aspirates much less but is not mobile, isn't sensing that, or has a very weak cough, has a lot of dysphagia, or it has a number of other health comorbidities. So we've got to consider these other things like Langmore, 1998, looked at, and Palmer and Padilla look at, that contribute to the adverse outcome that we're concerned with. And so not just aspiration, but look beyond that. And for so much of the stuff that we're looking beyond, like, okay, Is this patient at a higher risk or a lower risk of aspiration? We've got to consult with physicians and other individuals because we don't know all this stuff. And there's so much more data that we need. We have some, but we need so much more. I mean, this is a very, very long, in-depth conversation. And I think that's probably about as far as we'll get today. But there are other resources out there. I'm going to post some of these articles in the podcast description so you can take a look. I'm also working with MedBridge to come out with a 3-course series, and it'll probably won't be out till like mid next year or something like that. But I plan to let you know when that does come out. But also, Alicia Vose, Ed Weiss, Deb Suter, and I forget who the fourth person is. There's an article in publication, or it's soon to be published, that they're looking at that looks into this too. And what was really validating to me, I have a lot of respect for those individuals. I have a lot of respect for Alicia Vose, and I've worked with her a lot in the past at conferences. Like, she's come to the Hard to Swallow conference and has spoken probably 3 occasions. But so there was one year when she came to Provo, when it was a hybrid in-person online conference, and she was talking about, not to put words in her mouth, but the general idea was these pillars or these anchors we're looking at. We're looking at pulmonary health or health, nutrition, hydration, and quality of life, which I think they since have maybe adapted that terminology. But having us look at why dysphagia matters, and I felt so validated because independent of that discussion, I had been teaching this in my dysphagia courses. Like, this is why dysphagia matters. This is the impact of it. And so for somebody who I think is as brilliant as those individuals to come up with the same hypothesis or conclusion on their own, I was just like, yes. But now people are going to think when I talk about it that I'm copying them. That was so validating. And so kudos, keep an eye open for their work that should be coming out here pretty soon.
They are a great group. I know you're wanting to wrap up, and I did kind of have a heart out to go get my kids, but I wanted to finish my thoughts on the Robbins et al. Study as well from 2008. You were talking about limitations. Another limitation of this study that they call out is that they didn't have a no treatment group. Everybody had chin down nectar or honey. So it would have been interesting to see what happened to the people who did nothing and just carried on with their lives, maybe with some risk mitigation education, like keep your mouth clean or something like that. Yeah. It would have been very interesting to see, or even if they were residents of long-term care facilities or something. We know that oral care isn't great in those places. So it would have been very interesting to see what happened to a no treatment group as it compared to those 3 treatments. Mm-hmm. So that was one too. But as we talk about quality of life, nutrition, hydration, they do finish. I just pulled up the article because I was pretty sure that it touched on this. The very last paragraph says, and I'm just going to read it. Our findings should prompt clinicians to question the practice of recommending very thick liquids, in this case, 3,000 centipoise, without first evaluating all possible intervention options. And we've touched on this, Tim, or you did, and we did together, and considering the relative cost burden to the patient and care providers, not just in terms of dollars, but also quality of life. Period. End of article. Yeah. And so they were saying the same thing, that these treatments, you need to look at them from a broader perspective. Cost, which you brought up earlier. And they say quality of life. What do our patients need? Sure. Be happy, healthy, and successful in the life that they want to live.
And I think that's a great way to wrap this up. There's one thing that I'm going to throw out there. With the lenses that I look through, of course, I operationalize these things in different ways: nutrition, hydration, quality of life. And so within quality of life, at least when I'm looking at this, I'm considering, I don't know, not just like people's ability to go out and socialize and have a meal with other individuals, or their how much they're coughing when they eat and how much that's annoying them or bugging them, or it's causing vocal fold trauma or whatever. But I'm also looking at economic burden. When you consider the money that they have to pay, that's likely going to have an impact on their quality of life too. So I'm grouping that together. I'm sure these things will likely adapt and change through the years. This is just at least how I'm looking at it right now. But as we learn more, I'm sure we'll learn more. Yeah. We'll know more as we learn more.
Yeah.
There you go.
We're going to, the sky's the limit for speech pathologists, and this field, especially when it
Mhm.
comes to dysphagia practice, look how far we've come in 40 years.
Yeah.
Man, I hope I'm still alive in another 40 when I'm 80 plus, going to my nursing home prom. I don't want to see thick and liquid there at all, okay? I want us all to be hydrated with good nutrition, dancing on the dance floor. So, Tim, thanks for letting me hijack today.
Yeah. Thanks for
I'm
being
not
willing
sick
to
of you yet.
interrogate me.
We've spent some time together over the last month. Not sick of you yet.
Oh, hey, there we
Give
go.
it another month.
One more month. All right.
One more
Well,
month.
well, I truly appreciate it, Jeanette. And next week we'll be back to the normal of me talking to other people and interviewing them. But I just wanted to give some insight into this. I'm sure it'll be a topic that we talk about later in the future. But thanks so much for listening. And oh, Jeanette, you're supposed to do the outro. You're the host.
I don't know what your outro is. I don't listen to it enough. So,
Just say
you
peace
want me
out.
to outro your podcast like I outro my own?
I just say bye. Thanks for listening.
Okay.
We'll see
All
you.
right, guys. Thanks for fixing it. See you next week.
Thanks for hanging out. That was guest host Dr. Jeanette Benigas interviewing me about the idea of functional swallowing. Please check the description for some resources, and please don't hesitate to email me at tim@swallowthegap.com for further discussion or questions or, challenge any of these concepts. Certainly open to discussion in that. I really appreciate each one of you for the support that you bring, and I hope that you'll consider sharing this episode or another with your friends and colleagues. And with that, I will thank you once again and hope to see you next week.